So let's look at complications of EUS-CDS. These are the two randomized controlled trials published in the same year, 2023. The first, the Hong Kong study, the second, the Element trial from Canada. Both of these were multi-center trials. So the Hong Kong study showed comparing LAMS, CDS, versus ERCP as a first-line maneuver. Right? This is not failed ERCP and then going to LAMS CDS. This is a head-to-head comparison as a first-line maneuver for patients with malignant distal biliary obstruction. So the Hong Kong study showed that LAMS was superior to ERCP in terms of success rate and procedure time, less procedure time for LAMS. LAMS was equivalent to ERCP for patency and adverse events. And then in the Element trial, this showed that LAMS was superior to ERCP in procedure time, not surprising, but LAMS was equivalent to ERCP in terms of success, patency, adverse events, and quality of life. So at least equivalency and superiority, definitely for procedure time. Have we found the Holy Grail then? At least for malignant distal obstruction? We have eliminated difficult cannulation entirely with the LAMS CDS, and there's no post-ERCP pancreatitis. However, there is a key difference between EUS-CDS and ERCP that is not highlighted in either of these papers. And that is that with EUS-CDS, you really have just one chance at success. With ERCP, yes, there's a risk of pancreatitis, but you can stop and you can always retry on another day. With EUS-CDS, you may be looking at this scenario if you have a complication. So what sort of complications did we see in these trials? Well, this was in the Element trial. There were 6 maldeployments. 5 of these were the type 1, so maybe less serious, but there were 2 bile duct perforations, one with the proximal flange misdeployment. This is the type 2. You can see that the LAMS is entirely outside of the GI tract, so bile is flowing freely into the interposed space. That's really the peritoneum. And then type 3 is where the operator accidentally went through the opposite wall of the bile duct, and I would argue that's also a very serious complication. I would definitely be nervous, even though they claim both of these were endoscopically salvageable. And then the authors combined their data, did an analysis of their combined data sets, 152 patients, misdeployment rate of 7.2%, 82% salvage endoscopically. Most of these were the type 1, but there were also type 3. But importantly, their multivariate analysis showed that the most significant risk factor was the CBD that was less than 16 millimeters in dilation. And then we have from this year, this study, which is a compilation of retrospective from 23 centers, total failure rate of 7%, and they looked at the risk factors for failure with multivariate analysis. Now, sadly, this is a different classification than the one you saw from both the Hong Kong and the Canadian studies. So the type 2 is really the type 1. So this is where the LAMS is only in the digestive tract. We have the type 1 here that was in a quarter of the patients, where the LAMS was entirely in the CBD. So the proximal flange was no longer in the bowel. And when they looked at their risk factors, they too found that a diameter of 15 millimeters or less was significantly associated with complications. And there was also duodenostenosis using the wired technique and minimally experienced. That's not surprising. But this is what caught my attention. The 30-day mortality rate after failure, 12%. That, in my mind, is unacceptable. So let's go through some tips that I can share with you for a successful CDS. You should not do this in any patients with a duct less than 15 millimeters. So it really should be more than 15 millimeters. And I always try to find the long axis. And you can see here, if you orient towards the hilum, you can get a runway of 30 millimeters. Here you see the nose cone at the very tip. Here you see the distal flange. And again, to underscore, this is the runway here. This is the distance that you have to have your inner catheter inserted into the bile duct to safely deploy that distal flange. So this is the way we usually see it. Look, right behind the CBD is the hepatic artery, and then we have the portal vein. So if we're going to do it this way, we have a shorter runway than if we reorientate ourselves, and now we're looking at the hilum. This is a non-issue if the patient's not going to surgery. Obviously, if the patient's going to have a hepatico-jejunostomy, this could be an issue. So here we have a nice long runway. We can deploy our distal flange here safely and then snug it up against the wall of the duodenum and then deploy our proximal flange. And here you can see at the apex of the bulb, this is where we always aim, we're deploying the proximal flange. Let's move on to the next one. I'm trying to forward there. No. Second, infuse saline into the bulb to distend and flatten the folds. You want to avoid a double mucosal puncture. This is something that is increasingly being reported on. I think Dr. Ogura in particular has reported on this, and avoiding a pyloric ring, a pylorus puncture. So you always want to have your lambs here at the apex of the bulb, never at the pylorus like this. This is the double lumen puncture from Dr. Ogura's video GIE paper. Third, preload the delivery catheter with a guide wire. So you're going to insert that guide wire after you have punctured. Make sure that the guide wire is at the tip and that afterwards you anchor the position of that guide wire at the handle end. So you don't want that guide wire sticking out when you do your puncture, because that may impact the puncture. Once you're through, you can advance your wire into the upstream bile duct. You don't necessarily have to use fluoro. You can see it beautifully here, the guide wire coming out of the nose cone tip here. Deliver the distal flange slowly in increments. So here you can see the distal flange, and in this case, it is deployed outside of the bile duct. So what to do now? Well, fortunately, you can reverse what we did when we designed the handle, which was to prevent resheathing. We didn't want the operator to be able to easily resheath. But in this case, all you need to do is press down on this latch, and then you can advance the hub to recapture the distal flange. So that's the little trick. It will always work for an 8 and a 10 millimeter. Could be a little difficult with a 15, and it probably won't work with a 20. But it will definitely work with the 8 and the 10. So here this shows you how we recapture the distal flange. We've punctured into the gallbladder. We've passed our wire. Now you can see the runway is not as generous as one would like it to be. So despite using the incremental delivery technique where you sort of push and pull, you'll see here that the distal flange is deploying outside of the bile duct. And this is where your heart kind of stops or starts to race. And the solution is very easy if you have your assistant press down on that latch, and then you lock the gray hub and just advance it forward. And you can see it here slowly resheathing. So it's pulling that distal flange back into the sheath. And now you can redo it. You just need to be sure that you go more deeply into the bile duct. May have to use more of the push technique to really have it safely deploy in the bile duct. So incremental redeployment, as you can see here, and then it safely deploys inside of the bile duct. Here you can see the distal flange here. So this is actually intentionally showed in real time for you because this takes patience. You need to do this carefully. Incremental means in little small steps. And here is the bile now successfully draining. Finally, always place a double pigtail plastic stent through your lens because you want to have that axios or that lambs oriented towards the hilum, and you don't want the opposite wall collapsing down against the distal flange. And finally, never let the sun set on a failed CDS. You have created a hole in the bile duct. If you fail, then you have to drain the bile duct. And for our center, for me, it is an HGS. So that's where I'm going to pull back and I'm going to find a route to drain the bile duct with an HGS. So remember, the bile duct is under pressure. If you do not drain that duct, it will leak and you're going to have a bad outcome for the patient. Thank you very much.